Very good morning to all. Today's topic is aggressive periodontitis. We'll discuss about aggressive periodontitis. So what is aggressive periodontitis? Generally in perio, we have two broader disease categories. One is chronic periodontitis. The other one is aggressive periodontitis. Basically, periodontitis indicates once the disease gets transformed from gingivitis state and it starts affecting the alveolar bone, then it is indicated as periodontitis. Usually, periodontitis is an inflammatory disease which involves all the supporting tissues of the teeth. What are all the supporting tissues we know? Gingiva, periodontal ligament, cementum, and alveolar bone. So when all the supporting tissues are getting involved due to specific microorganisms, and it ends in an inflammatory condition. We refer that condition as periodontitis. So, periodontitis is basically defined as an inflammatory disease of the supporting tissues of the teeth caused by specific microorganisms, resulting in progressive destruction of periodontal ligament, alveolar bone. What may be the symptoms? It results in pocket formation, periodontal pocket formation, gingival recession, alveolar bone destruction, or all. Okay. So this is all about periodontitis. Under periodontitis, we have chronic periodontitis and aggressive periodontitis. What makes this difference? Let us see about the difference. Basically, the chronic and aggressive forms are classified based on the duration. The chronic means it is for a longer duration. Aggressive means the onset of action is minimal. So that is the main difference between the chronic and aggressive periodontitis. There are a lot more salient features to differentiate between both the diseases. We'll see it one by one. Okay. Coming to the history part, the history goes back to 1923. The first person, Gottlieb, he named this particular condition as diffuse atrophy of alveolar bone. There was a diffuse atrophy that is identified around the alveolar bone. There was loss of collagen fibers, and it was replaced with loose connective tissue that is basically inflammatory process. Extensive bone resorption, severe bone resorption, widening of the period space, and the gingiva apparently was not involved. The underlying period fibers, collagen fibers, alveolar bone, everything else was involved. So later, in 1989, during the World Workshop in Clinical Periodontics, it was named as localized juvenile periodontitis. The name juvenile was given because the persons who had this kind of disease was mostly were 30 years or under 30 years of age or around the circumpubertal age. So hence the name was given juvenile. Basically, juvenile means younger age. So hence this disease was during 1989 workshop, it was given as localized juvenile periodontitis. Most recently, it is named as aggressive periodontitis. After the recent classification, it is given the name aggressive periodontitis. So let's see in detail about aggressive periodontitis. Aggressive periodontitis comprises a group of rare, often severe, rapidly progressive forms of periodontitis. It is often characterized by an early age of onset. As I told you previously, the name was juvenile periodontitis because there was early age involvement. Clinical manifestation with destructive tendency and destructive tendencies of destruction in the the periodontal supporting tissues. And they identified there was a familial aggregation among this disease. Okay. So aggressive periodontitis describes three of the formally classified early onset periodontitis. They are localized aggressive periodontitis, generalized aggressive periodontitis, and rapidly progressive periodontitis. So let's see the difference between chronic and aggressive with certain features, salient features like age, rate of progression, microbial etiology, immunological etiology. What about age? In chronic periodontitis, it is more prevalent in adults, but maybe it present in children and adolescents also, but mostly it is seen in adults. So in aggressive periodontitis, in contrast to chronic periodontitis, we have circumpubertal onset. It is an important point. You have to note it down. It is one of the salient features of aggressive periodontitis. Circumpubertal onset is seen in LAP, and in GAP it is under 30 years of age, and usually older patients also, we can say older patients also. What about the rate of progression? In chronic, there is slow rate of progression, but in aggressive, we can see rapid rate of progression with pronounced episodic events of attachment and bone loss. As soon as the disease gets started, there is a rapid progression. The degree of bone loss is extensive compared to chronic periodontitis. What is microbial etiology? In microbial etiology, as we all know, a chronic periodontitis consists of both aerobic and anaerobic gram-positive and gram-negative, although gram-negative is predominant. Gram-negative basically P. gingivalis, where all the red complex organisms, okay? But in aggressive cases, the key microorganisms, Aggregatibacter, Actinomycetum comitans, and Prevotella intermedia. So coming to the immunological part, as far as the chronic periodontitis is concerned, there is no abnormalities detected in relation to immunological aspect. But in aggressive, we can see hyper-responsive macrophage phenotype and phagocytic abnormalities. There is phagocytic abnormalities. So from this, we can understand basically chronic periodontitis is because of the local factors. The origin is mainly because of the local factors. But in case of aggressive periodontitis, in spite of very minimal or nil local factors, we have extensive bone loss. What is the theory behind that? This particular type of disease, this particular type of periodontitis has immunological part, genetic part. So they all play a role, and which ends up in the extensive destruction of the alveolar bone. So as far as the treatment is concerned, for chronic periodontitis, where the removal of local factors is more than enough. So it will end up in a good treatment outcome. But in case of aggressive periodontitis, we should think about multifactorial part. We have to think about reducing the microbial load. We have to think about altering the immunological aspect. Only then the treatment outcome will be good. So coming to the distribution part in chronic periodontitis, it is considered localized when less than 30% of the sites are involved. It is considered as generalized when more than 30% of the sites are affected. But in case of aggressive periodontitis, we have few salient features which we should be very thorough. What is that? Let us see now. It is considered as localized when first molar and incisors and no more than 2 permanent teeth are involved. When it is considered as generalized, when at least 3 permanent teeth other than first molars and incisors are involved. So coming to local factors, as I told you a few minutes back, presence of local factors directly related to the amount of destruction present as far as chronic periodontitis. But in case of aggressive, presence of local factors does not commensurate with the amount of destruction present. As you can see, clinically, the patient will show up very minimal or rather nil calculus also, we can say very minimal local factors will be present. But if you take radiograph and check, or if you check with a periodontal probe, you can observe the periodontal pockets, and in radiographs, you can see extensive alveolar bone loss. Okay. So let us see the familial aggregation. It is very important point as according to aggressive. For chronic, there is no lack of strong evidence correlation between particular genes and periodontitis. But in case of aggressive, you can see evidence of strong familial aggregation. What are all the features of aggressive periodontitis? Already I discussed in detail in the previous slide. But according to Lang in 1999, there are 3 primary features. It is non-contributory medical history. That is, these patients will be otherwise systemically healthy. But in case of chronic periodontitis, in diagnosis itself, you used to write there is strong medical history. That is, we used to write generalized chronic periodontitis associated with diabetes mellitus. So what it indicates, chronic periodontitis, we have medical history is associated, but in case of generalized, the patient will be otherwise systemically healthy. The second point is rapid attachment loss and bone loss. And the third one is familial aggregation. So secondary features. As we saw in the previous slide, the amount of deposits does not commensurate with the severity of the periodontal destruction. So elevated proportions of aggregative bacter actinomycetum comitans is seen. Hyper-responsive macrophage phenotype and exaggerated response to bacterial endotoxins, and we can also observe phagocytic abnormalities. So aggressive periodontitis is broadly classified into localized aggressive and generalized aggressive. So localized aggressive periodontitis, clinically it is characterized as having localized first molar or incisor presentation with interproximal attachment loss on at least 2 permanent teeth, one of which is a first molar and involving no more than 2 teeth other than first molars and incisors. You have to by heart this. You can understand easily. Next, the clinical features of localized aggressive periodontitis. Age of onset is around puberty. That's why we say circumpubertal origin. Okay, that's why the name was given juvenile periodontitis, prepubertal periodontitis. So it affects both the sexes. Main characteristic feature affects mainly the first molars and incisors. So lack of clinical inflammation despite the presence of deep periodontal pockets. So plaque that is present forms thin biofilm on the teeth. So plaque contains elevated levels of AAC or Pheromonas gingivalis. In AAC, particularly the serotype B is predominant. So disease progresses rapidly, and plaque that is present forms a thin biofilm on the teeth and rarely mineralizes to form the calculus. So the local factors are very minimal. So the rate of bone loss is 3 to 4 times faster than in chronic periodontitis. A robust serum antibody response is also seen to the infecting agents. So in this picture, you can clearly see an angular bone loss between the premolar and first molar. It is a very typical feature of aggressive periodontitis. So other clinical findings, maxillary incisors migrate distally. That is, there is pathological migration, which is a salient feature for aggressive periodontitis cases, and increasing mobility. As there is a very deep periodontal pocket, you have increase in the mobility of the teeth and sensitivity of the denuded root surfaces to thermal and tactile stimuli, and deep, dull, radiating pain during mastication. Periodontal abscess may form because there is deep pockets. It's no wonder we have periodontal abscess, and due to abscess, you have regional lymph node enlargement. So coming to the radiographic finding, classic diagnostic sign of localized aggressive periodontitis is vertical bone loss or arch-shaped bone loss, angular bone loss. The vertical bone loss is observed around the alveolar bone, around the first molars and incisors. The other findings are arch-shaped bone loss can be appreciated. That is, it extends from the distal surface of the second premolar to the mesial surface of the second molar. We have an arc-shaped extensive bone loss when compared to the chronic periodontitis. The bone defects are usually very extensive. As you can see in the appreciate in the picture, we can see extensive arc-shaped bone loss from the premolar extending to the second molar. So coming to generalized aggressive periodontitis. Generalized aggressive periodontitis is characterized by generalized interproximal attachment loss affecting at least 3 permanent teeth other than first molars and incisors. First molars or incisors are default for aggressive periodontitis cases. When it is classified as generalized, other than first molars and incisors, at least 3 permanent teeth should get involved, and it is considered as aggressive. So even in this picture, you can see the local factors are very minimal. Only plaque you can see, and very mild calculus is present. Features of aggressive periodontitis. Usually, this particular periodontitis case, it affects only 30 years of age, or patients sometimes maybe older also. Poor serum antibody response to the infecting agents is seen in generalized aggressive periodontitis. So generalized interproximal attachment loss, you can see generalized alveolar bone loss, you can see, and the salient feature is arch-shaped bone loss, as we saw in the previous slide. In pronounced episodic nature of the destruction of attachment and alveolar bone loss is seen in generalized aggressive cases. So radiographic features no definitive pattern of distribution, ranges from severe bone loss, extensive bone loss associated with minimal number of teeth to advanced bone loss affecting the majority of teeth in the dentition. So patients with GAP demonstrate osseous destruction of 25 to 60% during a 9-week period. So this period of disease activity is very short duration. That's why the name aggressive periodontitis. But in case of chronic, it takes years. It takes years to end up with a severe destruction. So these are all the radiographic features. And as we discussed in the earlier slides, this is the difference between localized periodontitis, aggressive periodontitis, and generalized aggressive periodontitis. As far as age is concerned, for localized periodontitis, there is circumpubertal origin. But in case of aggressive, generalized, they are under 30 years of age, but older patients may also get involved. What about the distribution for localized aggressive cases? Localized first molar or incisor presentation with interproximal attachment loss, not involving more than 2 permanent teeth. What we saw for generalized aggressive cases, at least 3 permanent teeth should get involved other than first molars and incisors, and generalized interproximal bone loss is seen with extensive destruction. What about severity? Rapid and severe loss of attachment and loss of alveolar bone. But in case of aggressive, we saw episodic nature. There is episodic nature. The disease activity is actively present and there is a dormant stage and it comes in episodes. That is the difference between localized and aggressive. What about etiology? Predominantly, the microbial microorganism which is seen in LAP is AAC. But in case of generalized, you can see predominantly P. gingivalis, Porphyromonas gingivalis. What about immunological response? Robust serum antibody response to infective agents. But in case of GAP, there is poor serum antibody response. Presence of local factors, there is minimal local factor. There is marked plaque and calculus formation. What about familial pattern? Strong association. In this generalized case, it is unclear. It's unclear. Okay. What about gingival inflammation? Lack of clinical inflammation despite the presence of deep periodontal pockets and alveolar advanced bone loss. But in case of generalized, the clinical signs of gingival inflammation are evident. What about radiographic appearance? Vertical or arc-shaped bone loss around first molars and incisors. There is generalized extensive destruction or bone loss around involved teeth. That's why it comes under generalized aggressive periodontitis. So, till now we have seen what is aggressive periodontitis, the broad classification of aggressive periodontitis, the salient features of aggressive periodontitis, the difference between chronic and aggressive, the difference between localized aggressive and generalized aggressive, and also we saw about the radiographic features of both the forms of aggressive periodontitis. Coming to the risk factors of aggressive form of periodontitis. For chronic, there are many risk factors like systemic diseases, smoking, tobacco chewing, and also genetics also. But in case of aggressive, we have 4 broader risk factors. The one is microbiologic factors, immunologic factors, genetic factors, and environmental factors. Let's see one by one. Microbiologic factors, the presence of aggregatibacter actinomycetin comitans is a key agent in LAP, as we saw in the previous slide. Also, serotype B is predominant, as most studies say. So, AAC is a key agent in localized aggressive as it is present in higher numbers, higher concentration. The patient has higher titer of serum antibodies against AA. So what about the virulence factors possessed by AA? As for we all know, P. gingivalis, the gingipines is considered as the virulence factor. But for AAC, leukotoxin is very important. Leukotoxin is a primary virulence factor of AAC. Also, it is a gram-negative organism. Lipopolysaccharide, we can consider like lipopolysaccharide. We have proteases. That's why we have predominant proteases. That's why there is destruction, severe destruction of periodontal ligament and alveolar bone. Collagenases, that's why there is a destruction of collagen fibers. And surface-associated material affect immune response and lead to connective tissue destruction and bone resorption. All these destructions happens and is replaced by loose connective tissue, that is inflammatory cells. Okay. Coming to immunological factors, defective chemotaxis due to functional defect of PMNs, neutrophils, polymorphonuclear neutrophils are affected, and that's why there is defective functions related to the chemotaxis. So hyperresponsive monocytes are also seen. This hyperresponsive monocytes increase the amount of prostaglandin, which is responsible for alveolar bone loss. IL-1 alpha and IL-1 beta. IL-1 beta has other name as bone resorping pro-inflammatory cytokine. So because of this hyperresponsive monocytes, there is increase in amount of prostaglandin, IL-1 alpha, IL-1 beta. Hence, there is then result is severe destruction of alveolar bone. So the next point is human leukocyte antigen, that is HLA antigen A9 and B15 are recognized as candidate markers for aggressive periodontitis. You can see higher titer of HLA antigen. So coming to the next slide, genetic factors. Localized aggressive has familial aggregation. Segregation of linkage analysis has shown that presence of specific gene is responsible for the neutrophil abnormalities. This localized aggressive periodontitis, it runs in families. That's why we say familial aggregation. Transmission through autosomal dominant mode of inheritance. So what about environmental factors? Smoking has a significant influence in the progression of generalized aggressive periodontitis. Smokers have greater attachment loss than non-smokers because smoking affects all the immune system, vasculature, and the supporting tissues. Hence, the smokers generally, they also not only with the clinical symptoms or clinical features, also under the category treatment, also the outcome, the prognosis. A smoker is very bad compared to a non-smoker. Not only he has severe clinical features, but also in the treatment aspect, if you treat a non-smoker, the outcome, the prognosis will be good. But it is lesser in degree compared to a non-smoker. I mean, in smokers, it is bad. Treatment outcome is always questionable. So, conclusion, what we have seen till now is what is aggressive periodontitis? Aggressive periodontitis is nothing but an inflammatory condition of periodontal tissues. It affects the supporting tissues. It has 4 risk factors. That is, one is microbiological, immunological, environmental, and genetic factors. So it is the onset of diseases are rapid. There is rapid destruction, and as far as the treatment part, in contrast to chronic periodontitis, we have to think about reducing the microbial load. Only then we can achieve a proper prognosis and treatment outcome. Thank you.